Good morning. For those of you that don't know me, I'm Shahbaz. I'm one of the staff here. So I had originally signed up to give this grand rounds last year when I thought I was giving a talk at CAPE, thinking I could double dip a little bit. Well, I never wrote my CAPE talk, and CAPE got canceled, so obviously that plan backfired big time. So I made this talk especially just for you guys. This is not a talk about lightning injuries. This is a talk about pearls. So a bit of a disclaimer, I fully recognize that I have a nihilistic view on medicine. I think many of the things that we do, while well-intentioned, cause harm to patients. And while I maintain this stance from a medicine perspective, today I'm here to give you mostly cold, hard evidence on things that I have witnessed to be practice-changing, influential, or often done poorly and emerge. I'm 3 years out from residency now, so I've had the opportunity to work with most people in our department. So I think I have a pretty good sense of practice pattern, and I've also picked up on a ton of pearls from people in our group that I think are high yield and worth sharing. So my hope or the goal of this talk is for everyone to walk away with a few practical, practice-changing pearls. This is not a huge deep dive into a topic, but rather it's more of a mystery bag of high yield stuff. So since we have to do things virtually, the way I approach this talk is it's a podcast with pretty pictures. This is not going to be a nuanced talk about evidence. I have not copied and pasted anything from a journal. I want to give you the most high yield information I can in a short amount of time. When there's no evidence on something, I'll tell you, but most of the things we're talking about today are evidence-based. I've looked at the literature and I'm going to give you my interpretation without presenting all of the data. And if you're interested, I'll share my references after, and all of this will be posted on the EM Ottawa blog. Now, going with the podcast theme, a resident said to me the other day that the cadence of my voice reminded them of Aziz Ansari, and I'm pretty sure that is not a good thing. So this may actually be the worst podcast you've ever listened to. So I've broken this talk into three major areas. So we're going to focus on pharmacology, so drugs that work, drugs that don't. We're going to talk about psychiatry, and the last section is on flow. And like I said, we're going to move pretty quick. So if you miss anything, all of this is on the EM Ottawa blog already, so you can follow along there. Okay, so section one, we're going to talk about drugs. So patient presents with this rhythm strip. They're totally stable, normal vitals, no past medical history, don't take any medications. They're no contraindication to any meds. So think for a second what you'd like to give this person. And hopefully you guys are thinking adenosine or diltiazem. Now there's significant practice variation here, and I still see a lot of people preferentially reaching for adenosine. So I do want to highlight something about this. There's evidence that demonstrates that diltiazem is more successful than adenosine with less adverse events. And this is from a Cochrane review with studies incorporating over 600 patients. The most common adverse event that we do see with adenosine is that feeling of death. So this one, to me, is a bit of a no-brainer. Diltiazem is more successful than adenosine, and people don't feel as awful. Now, the question I always get from residents is, well, what about the hypotension that you're going to get with calcium channel blockers? Well, it doesn't really seem that that actually happens in these patients. So in over 600 patients, only one of them became hypotensive. And I think part of the reason for that is the dosing. You're giving DILT 20 milligrams in a mini bag over 10 to 20 minutes. The other great thing about this is you can write this as an order and then walk away from the bedside, go see another patient, whereas adenosine is a bit more labor intensive. You have to sit at the bedside with, 2 syringes and a stopcock, or et cetera. So the one caveat here is, so I'll use DILT over adenosine for SVT any day in the relatively stable, uncomplicated person. The caveat here is if you are not certain it's SVT, the ECG is a little bit wide, or you have some diagnostic uncertainty.
I know,
adenosine
it makes no sense.
Oh, someone's mic is still on. So if there's any diagnostic uncertainty, you're not sure what the native rhythm is, adenosine can really help the electrophysiologist determine what is ultimately going on. So if you do end up having to use adenosine, there's 2 pearls I have for you. The first is to pre-medicate patients with 2 puffs of Ventolin and 2 sprays of nitro. And the reason for this is that the feeling people get of death is caused by bronchospasm and vasospasm. And giving these 2 meds right before you push your adenosine is going to mitigate that a little bit. Now, there's no RCTs or fancy studies looking at this. It is sort of theoretical benefit. But anecdotally, patients say, that wasn't as bad as the last time I got adenosine. So there may be a signal there. Obviously, don't give them nitro if they're hypotensive. The second pearl is to mix your adenosine in a 20 cc syringe with sterile saline, and you flush the whole thing all at once, rather than messing around with, the adenosine and then a flush or using the stopcock method. There's evidence to show that this does not dilute your effect and actually increases your efficacy. So first dose is 6 milligrams, second dose is 12 milligrams. you're more likely using this 20 cc syringe technique to cardioavert the person versus your usual 2 syringe technique. Now, you could make the argument, why don't you just start off with 12 milligrams right off the bat? I couldn't find any evidence on whether 12 milligrams makes a patient feel way worse than 6 milligrams. So it's an interesting thought. It's definitely food for thought, but definitely do the 20 cc syringe technique regardless. Okay, next case. We've all seen this person. They have a seizure, they're on Dilantin, they come in, they've stopped seizing, they're at their baseline, but their Dilantin is subtherapeutic for whatever reason. And so we end up replacing their Dilantin, usually IV. Now, the problem with this is that IV Dilantin can cause hypotension and decreased LOC. And that decreased LOC on somebody who's already post-ictal is less ideal because it will really increase your ED length of stay. Now, there's a bunch of studies actually looking at giving Dilantin IV versus giving Dilantin PO. Now, the caveat here is obviously your patient has to be at baseline and be able to tolerate PO. But there's a bunch of studies showing that you can achieve therapeutic serum concentrations with PO Dilantin within 2 to 14 hours, depending on the study. And the most recent study found that this therapeutic Dilantin level was reached within 3 hours. When you give it IV, it's going to reach therapeutic levels at around 2 to 3 hours. Now, the main side effect reported with oral dosing is GI intolerance. So these studies all looked at giving people just a gram PO. There is some other studies looking at giving people 2 doses of 500 milligrams 2 hours apart because it is a little bit better tolerated. With that, it'll take around 14 hours to reach therapeutic serum concentrations. Now, the caveat here again is IV loading will occur faster. So if you're worried someone's going to seize again soon or they've had more than one seizure, IV Dilantin is probably the way to go. But in all other cases, it's very reasonable to give them 500 milligrams of Dilantin now and then give them 500 milligrams PO 2 hours later. And that can be in the ED if they're hanging around, or they can take it at home if they're a reliable patient. And there's good evidence to support that. So that's been a change in practice for me recently. Now, I fully recognize every time I change topics, it's going to take you a second to get your bearing because we're going to move through things pretty quick. So we're going to talk about antibiotics for a big chunk here. And there's this idea that penicillin and cephalosporin cross-reactivity approaches 10%. But this is a bad myth. This is a myth based on really bad science. To understand where this comes from, you need to know that in the 1950s, when this was first identified as a phenomenon, antibiotics were made in the same lab using the same fungus, and there was actual physical cross-contamination of powders. We're way better at making antibiotics now, and so subsequent studies have demonstrated that the rate of cross-reactivity between penicillins and cephalosporins actually approaches 0. And they found that people who have a serious penicillin allergy are 3 to 4 times more likely than a non-allergic control to have an allergic reaction to a structurally unrelated antibiotic. So penicillin allergies mean you're more likely to harbor an allergic reaction to any other antibiotic, not cephalosporins. And in fact, cephalosporin allergic reaction rate is around 0.02%. So of all the antibiotics you could give, cephalosporins are actually probably one of the safest in a pen-allergic patient. So it is totally reasonable to give pen-allergic patients cephalosporins. And I'll often write on these prescriptions that I'm aware of the penicillin allergy so that the pharmacist can dispense it and not send it back so the QA doc has to deal with it. And since we're talking about penicillin allergies, it's important to know that only 10% of them are real. 90% of penicillin allergies are not true allergies. And this is a problem because we often end up treating patients with second or third line therapy or with antibiotics that have way more side effects or antibiotics that are needlessly broad spectrum. And this can have significant downstream implications. So I'll give you an example. So this is my dog. He's super grumpy before he's had his coffee. And let's say he bites someone and they develop an infection. So ideally, you would treat them with amoxiclav. But if that patient's pen allergic, second-line therapy is either monotherapy with a fluoroquinolone or combination therapy with something like Doxy or Septra and Flagyl or Clinda. That's a nasty combination from a side effect standpoint. Clindamycin alone is associated with a 3 times increased risk of developing C. diff compared to any other antibiotic. And about 30% of patients who get Clinda are going to get diarrhea. So what can you do instead? Well, I just ask patients, what happened when you got penicillin? And if they have true anaphylaxis, okay, cool, stay away from the penicillin. But if they say almost anything else, like I was a kid, it was a long time ago, I don't remember, I had a rash, give them a dose of amoxiclav in the ED, tell them to wait 30, 60 minutes. If nothing happens, they can go home. write on the prescription that you're aware of the allergy, but you tested the person in the ED. So again, your QA doc doesn't get harassed. A lot of patients who say they're pen allergic, it's actually from childhood when they got antibiotics for a quote unquote strep throat, when really they just had mono and they developed the classic amoxicillin EBV rash. Our next pearl is in tribute to Dr. Yadav, because I know he feels as strongly about this next one as I do. So just pretend that this next learning point is actually coming from him. And for those of you that thought we were the same person, you can just carry on. The problem with virtual grand rounds is you can never tell when your jokes laugh because you don't. My only feedback is my dog staring at me. Okay, so we've all seen, heard, or done the following. Wow, that cellulitis looks really bad. We should give you a dose of IV antibiotics and send you home on oral antibiotics. Or the patient who is sent in by their doctor for IV antibiotics. And amongst physicians and patients, it is generally presumed that IV antibiotics are better or stronger than oral antibiotics. Now, outside of sepsis, where early source control is critical, oral and IV antibiotics actually tend to perform very similarly, assuming that the person can take PO and you've picked the right antibiotic. And this is because bioavailability. Now, I know the second I say that, I'm going to lose half of you, but it's an important concept because it is a myth that IV antibiotics are somehow better. If you're picking the right antibiotic in the right scenario, most bioavailability is going to be over 90%. So the same amount of antibiotic is getting to the source of infection regardless of the route of administration. The only real difference is going to be the time it takes to get there. So if you have someone who's septic and you need immediate source control, yes, give them IV antibiotics. But for most other scenarios, the idea that IV is better than PO is a myth because the bacterium in your tissues is ignorant of the antibiotic's port of entry. And there's evidence to support this. So let's talk about cellulitis specifically for a second. There's a Cochrane review with over 25 RCTs and over 2,500 patients. And what they found was that in every single study, IV was not superior to PO. And in many of these studies, PO actually was superior to IV antibiotics for the treatment of moderate and severe cellulitis. Similarly, there's studies looking at this for pneumonia in adults and children, over 8 studies. In all the studies, PO was not inferior, and in many of the studies, PO was greater than IV. There's also a Cochrane review showing that PO was greater than IV antibiotics for febrile neutropenia, chronic osteo, and peds pyelonephritis. And there's another 15 RCTs in adults and children looking at UTIs that showed no difference between oral and IV antibiotics. When we think about cellulitis again, there's an IDSA guideline that goes along with this. They recommend that IV antibiotics for non-purulent cellulitis should be reserved for patients who are immunocompromised, have systemic signs of infection, hemodynamically unstable, altered mental status. And in fact, when you adhere to this guideline, it shows a decrease in treatment failure rates in the ED. Now, one reason that IV antibiotics are so overused is the incorrect diagnosis of treatment failure. All too often, patients with cellulitis and other infections have cellulitis, or infections like pneumonias, UTI. They've been deemed to fail oral antibiotics after less than 48 hours. And then they're unnecessarily switched to IV antibiotics. There's no evidence to support this practice. Treatment failure of a simple cellulitis should only be entertained after 48 to 72 hours of oral antibiotics. And in a lot of those cases, it's sufficient to just switch classes of oral antibiotics. IV antibiotics are not the automatic answer to treatment failure. And so I personally think, and my recommendation after all the evidence, is that patients should have at least 48 to 72 hours of oral antibiotics before you change to IV. Obviously, if they're becoming septic or really unwell, that's your exception. Also, giving someone a dose of IV antibiotics and sending them home on oral antibiotics should not be routine practice. There is no evidence to support this. And all you're going to do is cause increased harm. They did a study where they took patients who had cellulitis. Everyone was sent home on oral antibiotics, but half of them were randomized to receiving IV antibiotics in the ED. There was no improvement in treatment rates, but there was a significant increase in diarrheal illness and C. diff in the group that got the IV antibiotic in the ED. Plus, there's all the other complications, right? Thrombosis, phlebitis, infections, bacteremia, and often to facilitate outpatient treatment, we use unnecessarily broad-spectrum antibiotics, resulting in significant downstream harm. Now, if you're uncomfortable with this change in practice, perhaps the middle ground is to consider oral antibiotics in all of those patients who don't have risk factors for treatment failure. Unfortunately, Dr. Yadav has already done this research for us. But to be fair, I still think these patients deserve a trial of oral antibiotics before assuming treatment failure, because these are patients who are high risk for developing antibiotic resistance. And on a population level, we can save a lot of them harm by minimizing erroneous IV antibiotic usage. Now, since we're talking about antibiotics, I want to talk about gut health for a second, because we're doing a lot of iatrogenic harm, especially when we mix classes of antibiotics in the same person. And that's because one dose of any antibiotic can change your gut microbiome for 6 to 12 months. And in some patients, they never recover. Now, so what? Does this have an impact on anybody's life? Well, maybe. So there's studies linking patients who have fibromyalgia and IBS and compared their gut microbiology to healthy controls. And there is a significant difference in the bacteria that reside there. Now, obviously, this is multifactorial, but it is very plausible that antibiotics are playing a role in these illnesses. And I think it'd be presumptuous of us to suggest that we are not having a significant downstream impact on patients as a result of some of our unnecessary actions. As an aside, like when I have a patient who certainly has IBS, this is my biologic plausibility argument to describe what and where I believe their pathology to be coming from. So to summarize the antibiotic bit again, cross-reactivity is a myth, and most penicillin allergies are not real. Remember that IV antibiotics are not better than PO, and there's no reason to give a dose of IV antibiotics and send someone home on oral antibiotics, and that gut health matters, and we have to be cognizant of the harms we are doing to patients. Okay, so I'm gonna stop talking about antibiotics and move on. So cannabis hyperemesis syndrome, you can usually tell when this is in the ED because you can hear the person retching down the hallway, and then everyone plays this game of hot potato to not pick up that chart. It's a challenging disease entity because the symptoms can be so hard to manage. The evidence around this stuff is pretty weak, and there's not a lot of science, but there are some treatment suggestions. And I do think an approach to these patients is important because they present to the ED a lot. There's a lot of practice variation, and if we can treat them early in their course, we can often decrease their length of stay and minimize a lot of unnecessary investigations. And I'm specifically thinking about imaging. Their abdominal discomfort pushes a lot of people towards imaging, but aggressive treatment at the front can maybe help you mitigate that. So the literature actually talks about giving up to 16 milligrams of Zofran, which I hadn't seen or done before, but it definitely is cited in there. So it's something I have in the back of my brain. I haven't used it yet, but I would definitely get an ECG before giving that kind of dose. Haldol 2 milligrams is probably the sweet spot. The gastroparesis literature extrapolates using 5 milligrams of Haldol, but anecdotally, I don't know what it is about patients with cannabinoid hyperemesis syndrome. I don't know if it's the pot. I don't know if they're predisposed, but they seem to be developing a lot of EPS at the 5 milligram dose. I couldn't find any evidence about that, but it just seems to be my experience. And so I think 2 milligrams is that sweet spot, plus 2 milligrams is the antiemetic dosing. And the last one is capsaicin cream. You give 0.075%, you just rub it on the belly. I don't know why it works. It's unclear, but it definitely seems to work. When I first see these patients, I order it immediately because it can take a bit of time to come up from pharmacy. And then a tip for the residents is to try and set the agenda off the bat when you see patients like this. I say something like, the goal is to get you home today. We have a couple medications to try and throw at you, and then you use the prescription for the capsaicin cream as your carrot at the end. Changing topics again. I don't know who needs to hear this, but Tamiflu doesn't work. Now, this is going to be a bit of a rant. I recognize that we often aren't the ones prescribing Tamiflu, but our colleagues certainly are, and so we need to know about this. So a bit of a history lesson. So Tamiflu was approved by licensing agencies and promoted by the WHO based on unpublished trials. And the key authors of, the primary authors of the key Tamiflu trials were never given the final data from Roche. And actually, the BMJ was involved in a legal battle with Roche for 5 years just to get the data. When they finally got the data, it appeared that Tamiflu had no impact on complications, was not helpful in prophylaxis, and had multiple harms. So this was published. And there's been a bunch of studies looking at Tamiflu, and in the Cochrane review, the only demonstrable benefit that they've seen anywhere is a decrease in symptoms by 17 hours. But it should be noted that that benefit is based on studies that have huge risk of bias, selective reporting, attrition, significant author conflict, and that negative trials weren't published. But there are many documented harms. So the NNT is infinity. It doesn't help anybody, but there are many potential harms with fairly low NNHs. Now, this study came out in 2020 to try and provide proof that Tamiflu works. And because it's in the Lancet, you're supposed to immediately be impressed and assume it's a good study, right? Well, maybe since Lancet pulled the hydroxychloroquine paper last year, maybe your impression of them has gone down. And I said I wasn't going to dissect any scientific papers, but I totally lied. I'm going to do this one because I want to prove a point real quick. This was a pragmatic, open-labeled, multi-center randomized control trial that was not blinded. It was in patients who had a flu-like illness within 72 hours of symptom onset, and they either got Tamiflu and the control group got nothing. Everyone got usual therapy. And the outcome was subjective. It was a patient-reported symptom recovery. And they said they had over 3,000 patients and that the benefit to Tamiflu was it decreased the duration of illness by 24 hours. No difference in any other outcomes. And that's what they said was the benefit of Tamiflu. And after reading this, I felt like I was taking crazy pills because this is an unblinded trial measuring a subjective outcome. With that combination, you expect a ton of bias. You expect that patients who get Tamiflu are going to think they're going to get better, while patients who are given nothing are going to feel worse. There's no reason to design a trial that way. It's ridiculous. And interestingly, when you comb through the study, Tamiflu was equally effective whether or not you actually had the flu. If you don't have the flu, there is no biologic mechanism by which Tamiflu should make you feel better. They felt better because they were given a placebo, just like patients who had influenza. So this study doesn't demonstrate that Tamiflu works. It demonstrates that the placebo effect is real. Now, there's actually a lawsuit against Roche for $1.5 billion for misleading the public and the government into stockpiling massive amounts of this drug. All of this is to say, just be careful what therapies you subscribe to. You're allowed to have your own practice pattern, but make sure you're aware of the evidence behind the decisions you're making. Read a paper, come to your own conclusions. Just because that Tamiflu paper is published in the Lancet and has some improvement in symptom relief doesn't mean it's a good paper. It's awful. So I would give this methodology 1 out of 5, usefulness 1 out of 5. Okay, I'm gonna stop ranting. I'm gonna move on. Residents, you get this ECG, 5 seconds in your mind. What is your treatment for this patient? I had learned from the so scholarly Dr. Nick Costain that the best way to tell if a T wave is peaked is to ask yourself, would I sit on those T waves? If the answer is no, then it's a peak T wave. So hopefully this is what you guys wrote down. This is conventionally what we're always taught to treat hyperkalemia. But there's a bit of a problem with this. A lot of these patients actually go on to develop hypoglycemia, and it's often when we don't see it. They're at dialysis or they're beyond our care. And the reason for that is the insulin is going to kick around for 4 hours. The dextro is only going to last about an hour. So there's actually some recommendations to use 5 units of insulin instead of 10, that you have similar efficacy in terms of shifting, but that you have less hypoglycemia. Now the caveat is in the severely hyperkalemic patient with dysrhythmia, probably still use 10 units of insulin. But in everyone else, it's reasonable to use 5. And that the recommendation is to actually give 2 amps of D50. Now you could give 2 amps right off the bat, or what I've started to do is I repeat my second dose in an hour or 2, and I write that at the same time as my first dose. So to summarize the first section here, diltiazem is better than adenosine for the treatment of uncomplicated SVT. If you do have to use adenosine, give Ventolin and nitro before you do it, and put it all in a 20 cc syringe and flush it all at once. Try to load patients with Dilantin orally rather than IV. With antibiotics, penicillin and cephalosporin cross-reactivity is not real. Don't be afraid to antibiotic challenge your quote-unquote penicillin allergies. Antibiotics do bad things to our guts. You got to remember what you're giving and why. And remember that IV antibiotics are not better than oral, and that there's no evidence to use IV antibiotics and send someone home on oral. Treat CHS with Zofran, Haldol, capsaicin cream. Tamiflu doesn't work. And for hyperkalemia, use 5 units of insulin and 2 amps of D50. Now, you may not have heard of the Eric-Clark sign before. It is when there are more abnormal than normal lab values. It necessitates admission. Okay, so let's switch gears and talk a little psychiatry. And specifically, we're going to focus on patients with depression, anxiety, and suicidal ideation. I think it's fair to say in the last 5 years or so, we've noticed a significant increase in mental health related complaints in the ED. And right now, especially during COVID, we're seeing a lot. And historically, what I was always taught was a safety assessment for patients. And as a result, I felt we weren't often doing anything helpful for people. Or we consulted psychiatry for patients that they would send home. And I think we can do a little bit better. What I'm going to advocate is that you have to spend some time talking to these patients, and it is going to be time consuming. But you'll find that when you engage these patients, you can make a difference, and it can mitigate some of the negative reactions and countertransference that you often have when you're picking up an anxiety or depression chart. I don't think it's a big secret that people tend to cherry pick around these cases. Now, in this section, I'm not going to talk about medications. The evidence for antidepressants is questionable at best. And once again, this represents an industry that makes up billions of dollars. Top 35 medications in the world that are prescribed, 5 of them are antidepressants. And there are hundreds of studies looking at them, but only a really few robust meta-analyses. And the problem with all of these trials is they're heavily biased, and the negative trials aren't published. And the reality is when you take a serious look at the depression-based studies, SSRIs are likely not much better than placebo. It appears that they may have a role in anxiety disorders, but for depression, it's likely low yield in most patients, or we haven't identified the patients that truly benefit. And intuitively, you all know this to be true because the SI and depression patients you're seeing are already on 2 or 3 of these medications, or they've been on lots of these medications in the past. So panic attacks. We've all been in that scenario where either A, a patient is having a panic attack right in front of you, or B, tells you they're afraid of another one happening. And this is where physicians will often reach for benzos, but as you know, that's a dangerous road to start traveling down. So I have some other evidence-based suggestions for helping people cope with their panic attacks. So one is box breathing. This is where you have the patient breathe in for 4 seconds, they hold it for 4 seconds, they exhale for 4, and they hold for 4. And they do 4 cycles of this. And that just helps to settle them down and anchor. Another exercise that works there is breathing in and out of a paper bag, not a plastic bag, but a paper bag. Another one is a grounding exercise. You have the person look around the room and tell themselves a story with the objects in the room. Again, it's a distraction technique. Third one is a symptom focus. So if they're having a lot of symptoms with their panic attack, tell them to focus on the symptoms to the degree that they'd be able to describe it to a doctor with as much detail as possible. So your hand is numb. Which fingers exactly are numb? What part of your arm is numb? Your palpitations you're having? How fast is your heart rate? And as they start to focus on their symptoms, they actually tend to go away. And the last thing is gonna sound silly, but it's guided meditation. And I know that sounds ridiculous in the emergency department, but more than once during the COVID era, which you can read in that it wasn't very busy, so I had the time to spend with a patient. But a patient was having a panic attack in front of me. So I opened up Spotify on my phone and I played them a guided meditation track. And I just told them to close their eyes and breathe. And they got to listen to a way more soothing and calming voice than mine. And it helped to settle them down. And after that, I was able to take a history. Now, it is important to remember in these patients that there are 2 aspects to treating their anxiety and their panic attacks. One is what to do when they occur. The second is to try and uncover why they're having them in the first place and direct them to psych or counseling as appropriate. Now, when we're talking about anxiety, it's important to remember that it has an evolutionary benefit. Everyone feels anxiety. I don't know about you guys, but fear-based learning, that was my jam in med school and residency. When it's clear that someone's presentation is due to anxiety or they have concerns related to their mood, you need to figure out why today and what specifically. And to be fair, sometimes there's no answer. But if you can delve into what's driving their mood, it'll really help. Some helpful questions are, what do you think is driving your anxiety? Is there anything you're particularly stressed about right now? How do you cope with stress and difficult things going on in your life? Remember, whatever the mood disorder, these people deal with it day in and day out, but they don't normally come to the ED. So isolating what is different today can be very helpful. Just like any patient with a chronic pain disorder, trying to find out what is new today can really help you help that person. And I can't emphasize that point enough. You've got to ask about substance use, especially pot. 15 to 20% of Canadians are using cannabis. And in the 25 to 34 age group, it's up to 25%. I suspect these are also higher during COVID right now. It's also important to remember that cannabis use is twice as high in those with mental health disorders. And it's often that patients with depression and anxiety are using marijuana as their method of self-medicating. Now, there is some stuff we know about this from the literature. So marijuana has 2 forms, THC and CBD. THC is more psychotropic. It's what kids are taking to, what people are taking to get high. CBD, we see it used more in pain, anxiety, cancer. It's less of a psychotropic effect. It doesn't act on the same cannabinoid receptors in the CNS, so they don't tend to feel stoned. Now, we know that THC is the most likely to increase anxiety. Some literature suggests at lower doses it may help lessen anxiety, but much more data shows it increases it. Most of the data on suggests it lessens anxiety, but this is acutely. It's like a benzo. In the moment, it will help you, but this benefit doesn't continue forward. Which makes sense. No matter what you're self-medicating with, if you don't take care of the issues causing your anxiety or you don't address it, it'll continue to cause you psychological distress. And from a mental health perspective, it's important to remind patients that the crappy stuff going on in their lives, unfortunately, they got to deal with it. Pot's an escape, but you can't run from your problems forever. and that their anxiety is really their body's way of telling them to deal with things. I also fully acknowledge it's hilarious. The paper I'm quoting here is by an author named Stoner. Now, one of the things I try to tackle in patients with mood disorder and marijuana use is harm reduction. I try to counsel them on stopping their pot use. It's making things worse. They're just self-medicating, and it's becoming a problem, especially in kids under 25. We know pot has a much more significant impact on a young, not fully developed brain. Now, usually, you get a pretty quick sense of when someone is engaged or not. I really like a line Peter John uses. He uses this normally in cannabinoid hyperemesis syndrome, but I think it extrapolates here, and it's, some people can smoke pot successfully without problems. Unfortunately, you are not one of those people. Now, if I get the sense that they're not even pre-contemplative, ideally you want them to stop smoking pot. But if they are clearly not engaged in that, I try to encourage them to do some harm reduction things. So one of those is to not smoke weed all day, to use it as a reward. Oftentimes they'll smoke throughout the day, they'll feel really lazy, they won't accomplish anything, it'll worsen their mood, and then they get stuck in this awful feedback loop. It's important for them to take breaks so that they can get normal sleep. A lot of people say they smoke pot to go to sleep and that it helps them sleep. But the problem is when you're smoking pot, you don't get true REM sleep. So you're not actually getting a really good restful sleep. They're just going through the motions. So it is important that they take breaks so that they can sleep normally, because this will definitely help lessen their anxieties. It's also worth noting that because they don't get REM sleep, when people do stop smoking pot, they often get very vivid dreams, and that's a very normal phenomenon. Consider CBD over THC, and to stop all high THC containing products, because that will again worsen your anxiety. And the last thing is not to combine it with alcohol, because it really potentiates the depressive effect of marijuana. When we're seeing people in their 20s and 30s who are using pot regularly, a theme I often hear is that they've been using it since their teen years. So a message I feel is important to impart to them is that they've been self-medicating for so long that we don't really have a sense of who is under that current shell. Until they're sober, we won't have a good sense of where their anxiety, their mood, etc. actually is, because they've been masking it for so long. And the last thing with these patients is part of where their anxiety comes from is the fight or flight response. And in modern days, it's not being as stimulated as it once was. The fight or flight response was helpful 5,000 years ago when we're running away from lions and tigers and stuff. It's the result of, I'm hungry, I need to hunt something and eat it. It's coded within our DNA. Now, you can get food delivered to your house and you don't even have to stop watching Netflix. People need to appreciate this message and then understand that they need to feed their fight or flight response. They need actionable items. They need homework. So I will full on write this as a prescription for people. And I'm going to say, if you're going to take anything away from the psychiatry section, it is this one slide. There's no doubt that exercise helps patients with depressive symptoms. The hard part is overcoming the depression to do the exercise. And this is why the prescription idea is helpful. Patients probably don't want to do it, but they need to. They wake up in the morning, they feel crappy, they don't want to do anything. They can't envision how some exercise is going to help. But you got to drag your ass out of bed and you just got to do it. Steve Troy will love this analogy. Joe Rogan often talks about how when he's feeling down or depressed, he works out as hard as he can until he can't move. And when he's exhausted, nothing else seems to matter. Exercise does help, and there's evidence to support that. Productivity is important. When people are engaged, it helps provide meaning, which will also help with depression and anxiety. And it doesn't matter what this is. This could be work, it could be a project, it could be organizing or cleaning. It could some days just be taking a shower and putting on pants in the morning. To-do lists help lessen anxiety symptoms, and you want to unbox this as much as possible. And I literally mean write down a list with check boxes. And instead of writing down like do laundry, put on there wash clothes, dry clothes, fold clothes. And every checkbox helps to minimize symptoms. Everyone needs a hobby. Everyone has to have something they enjoy. A recently published study showed that in patients who engage in a hobby, whether that was pre-existing or taking on a new one, resulted in a 30% decrease in depressive symptoms. And that doing this was also had an odds ratio of 3 of recovering from that depressive episode. Hobbies are very important. And the last thing is to do something social every day. One of the initial symptoms of depression is withdrawing from your social contacts and supports. So I try to encourage people to continue to do something social every day, even if nowadays it's something socially distant. Now, patients will often say that they're trying to do these things, or they know that they need to do these things, but they lack the motivation to do so. The analogy I give here is when patients have cancer, they don't want to do chemotherapy. It sucks, but they do it because it can help them get better. With depression and anxiety, you got to think of these as mental health disorders as well. You got to think of these mental health disorders as a disease as well, and that the medication we know that helps people is this stuff. If we had a magic pill to fix everything right away, we would totally use it, but we don't. And that's why this as a prescription can be helpful. Now, specifically for patients who are voicing suicidality, there's a bunch of questions that I've stolen from Dr. Boyles and some other psychiatrists over the years that I really like. One of them is, on a scale of 1 to 10, how suicidal do you feel today? And where do you sit on a normal day? And inevitably, they say something to the effect of they're a 7 today and they're normally a 5, something like that. And what they're trying to say is that they're suicidal every day, but that today is different. Now, what I ask them is, so every day you feel suicidal, but you're not here in crisis. You're able to cope at home. So what's different today? And you try to find what that thing is and figure out, if it wasn't for that thing, would you be here in the emerge today? And are you able to help them deal with whatever that stressor is? And this doesn't take an expert. Remember that all of you are high-functioning individuals because you have coping strategies to deal with the stuff life throws your way, while a lot of these people don't, or they don't use them effectively. And that's where you can come into play and act more as a coach on your assessment. Now, a question I get from a lot of juniors is, what do you do when a patient continuously endorses feeling suicidal? And the idea there is you want to work around that by separating the ideas of active and passive suicidality, because that person is usually always suicidal. So instead, you want to talk about future plans. So I ask, what are they going to do when they get home today? And if they say, I'm going to kill myself, well, yeah, okay, that person probably should see psych. But invariably, they say something like, I'm going to sleep, I'm going to go to the mall, I'm going to play video games. You know, what are your plans for Easter, Thanksgiving, Christmas, next weekend, whatever? Is there anyone that can be there with you today or tomorrow? So can you build in a safety blanket? And if you feel in crisis in a few days, what's your next plan? So is there anything that you can do to help facilitate outpatient therapy, like mobile crisis, for example? So what you're doing is you're assessing if their suicidality is active or passive without directly asking the question. Now, obviously, documentation is important. So I stole this phrase from Dr. Boyles. Based on my assessment, I have no acute safety concerns. However, due to the patient's history of borderline personality disorder, they're at chronically elevated suicide risk due to non-modifiable risk factors over which I have no control. So I put that on the bottom of all of these charts. Now, this approach won't always work. Sometimes you can't establish a therapeutic relationship and you can't get around the patient's suicidality. Now, you can't win them all. This is not a you problem. This is a medicine problem. Always remember the NNT. Example, the NNT for aspirin in ACS is 42. You help 1 out of every 42 patients with a therapy. So same with patients with depression, anxiety, suicidality. Sometimes on your assessment, you'll have a meaningful impact. Other times you won't. But simply by listening and trying to help problem solve, you'll make a lot of people better. People that we know, hospital admissions and medications just don't help. But don't be afraid to throw in the towel. I will consult psych at times when I can't establish a therapeutic relationship with a patient, or they need more DBT or time or counseling than I have the time or skill set to provide and emerge. So what I say when I call psych is I think, the suicidal person can probably go home. They just need a bit more TLC than I have the time or skill set to provide because I haven't been able to establish that therapeutic relationship. And psych is always okay with that. It's more distressing when we, quote unquote, lie to them and say that the suicidality is why the person needs to see psych, when in reality, we all know that psych's going to send that person home. Okay, everyone take a big stretch, swig of coffee, 2 seconds before we go on to the next topic. When my kid was figuring out how to crawl, he would just do downward dogs until he figured it out. I asked Andrew G, what's the best way to avoid getting a patient complaint? And he said, explain your thinking, admit when you're uncertain, tell them what you've been doing, but most importantly, be nice to everyone. It's easy to be nice to nice people, but you got to be nice to assholes too. Okay, the last section is flow. Now, I was supposed to give a talk at Cape on flow. Since that got canceled, I figured I'd drop these pearls with you guys instead. So the first one is specific to Epic. When you're charting, there's so many time-consuming taps, clicks, loading screens, etc., that you want to minimize the amount of erroneous times you spend navigating the system. So when I sit down to chart, I'm trying not to chart on one person at a time because that's too inefficient. Now, how aggressive you want to be with this is up to you. You can see 2 to 3 patients at once, but you need to have situational awareness when you do this. You need to know how many docs you have, how many patients are in rooms, what your learners are. You don't want to get trapped in a room, or you don't want people to languish because you've signed up for them and haven't seen them. So you have to be aware of that. But there's other ways you can do it. You could see a patient, sign up for another one, go see them, and then chart on 2 or 3 or defer your charting. But the principle is that you should not see a person chart on Epic, see a person chart on Epic, see a person chart on Epic. That's so inefficient. And so there's better ways you can do that. You also want to avoid redundant charting, and I'm super guilty of this, and this is one thing I'm always working on. But there's no point in double or triple charting. Like if you write that a person is PERC negative, you don't also need to write there's no risk factors for PE. That redundancy slows your charting down. And a place we see this is really since EPIC rolled out. I love what Eric Clark said. He said, people used to write 5 illegible words on their chart, and now with EPIC, they're dictating novels. And that point is very true. Like you don't need to write a 3-paragraph essay on a person. You just really need to write pertinent details. Reassessment land is probably the #1 thing that slows people down. And admittedly, sometimes it's unavoidable, but you need to be cognizant of this hazard in order to get better at it. When people try to go faster, they see a bunch of patients in their first few hours and they're super efficient. They think they're crushing it. And then they get stuck reassessing all those patients for the next 2 hours and don't see anybody new. You need more of an assembly line approach. There's evidence that shows patients would rather be seen sooner and wait longer for testing than the other way around. So when I have multiple reassessments, I will see 1 or 2 of them while grabbing 1 to 2 new patients to see with it. So yes, some of my reassessments may wait longer, but I am constantly pushing new volume. Now the caveat to this is when you have to optimize bed flow. So if you're an obs or emergent and you need the beds, your #1 priority is discharges to help facilitate movement through the ED. Actions per minute is a concept from video games. And the idea is that the more things you can do in a minute, more resources you harvest, whatever, the more effective you're going to be. Same thing goes for emerge docs. The more actions you can do in an hour, the more efficient you're going to be. Now, while it seems like a simple concept, it's a skill that you really, really need to practice. Now, I do this with like R3, R4 residents, and they've started calling it a character building shift. So I check in with them every 2 hours, and they tell me what they plan on doing for the next 2 hours. They say, I'll review 2 cases, I'll see 2 in OBS, I'll do a procedure. And my response is, great, you're also going to see 2 urgent care patients in that time. And they'll feel a bit of stress inoculation, but there's 2 outcomes. One is they realize that they can do more in an hour than they thought they had the capacity to do. And when they reflect a few months later, they find their shift-to-shift productivity goes up because they continue to realize that they can keep pushing themselves to do more and more in an hour than they originally thought they can do. So you can always be building on this. Second option is they're unable to get to urgent care. And then it's a great learning opportunity to try and identify what the rate limiting steps are. Geographic awareness is super important, especially on nights and especially with float shifts. You need to do things that are a geographically efficient manner. On an elective once, I tracked how many steps I took with the number of patients I saw, and I found that the more I was walking around on shift, the fewer patients I was seeing because I was just being inefficient. So you want to make sure you do all the job-related tasks you need to when you're in any given place. So on a night shift, when you get called from urgent care to resus, on your way back to urgent care, reassess the emergent care patient or go see that abdo pain patient that your learner reviewed that you hadn't seen yet. You want to carry the tools you need, especially with COVID. You want to minimize the number of times you go in and out of a room or do things inefficiently. Like if you're going to go see a first trimester bleed, take the ultrasound in with you. You know you're going to use it. Likewise, if a patient does not need their AVS, like they sprain their ankle, and you want them to take Advil Tylenol, have a scrap notepad in your pocket and just write the doses of Advil Tylenol. It minimizes the number of erroneous steps that you end up taking. Forecasting in the future is especially important for junior residents. You want to have a plan for where the first, second, or third antiemetic or migraine therapy fails, so that when you do reassess a patient, it's quick and easy. So you're always thinking 2 or 3 steps ahead of where you need to be or what you're going to do, so that when you're walking past the person in urgent care, you can do a quick, hey, how are you feeling, to determine whether or not you need your next line therapy, and it makes for quick reassessments. Definitely dictate. It's for sure faster. There's evidence to support this. When EPIC rolled out, I didn't dictate. I thought, I'm a really fast typer, I'll just keep typing. And then I switched to dictation after about 6 months, and I was exponentially faster with dictation. There's also evidence to show that physicians are statistically less likely to be interrupted when they're dictating versus typing. People see you're dictating and they're less likely to start talking to you. So maybe at least just use this the next time you're working next to Lauren. I'm just kidding, Lauren, we love you. Autopilot orders. If it can be autopiloted or written in advance, do it. It helps your cognitive load and that'll help your efficiency. So whether it's analgesia or, if you're going to diurese someone, I always write an order for, walk test after the patient diureses, after my Lasix order. Autopilot chest pain patients home, Give them your spiel, discharge instructions, etc. Tell them they're likely going home if their blood work's normal. Anything you can do at autopilot will help you from an efficiency standpoint. This is a bit of a flow / teaching hack. So what this allows you, so every 2 hours or so, especially with senior residents, especially on night shifts, I run the board. And what it allows me to do is I get a sense of what's going on with all of the patients in the department. And as they tell me about their people, I'm able to teach them at least one thing around their cases. The second thing I do is I tell them about all of my patients and what I'm doing with them. And it helps learners appreciate practice variation. And again, you can teach them something. So if all you did was every 2 or 3 hours, you did that on shift, that would be so much teaching you'd provide to your learner while still having a great sense of what's going on in the ED. The last pearl I have for you is to take a break. Seriously. At the end of a shift, we're tired, we have decision fatigue, and this fatigue can lead to indecisiveness and poor decision making or inefficiency. Grab a snack in the last 2 hours of your shift. It'll help your brain make the important decisions it needs to at the end of shift, and it'll make sure you're making efficient decisions. This is probably the only time I think you'll ever catch Dr. G eating a chocolate bar. So, to summarize my flow section here, you want to bunch your charting. So you don't want to chart on one person at a time in Epic. It's too inefficient. You want to try and avoid reassessment land. You want to increase your actions per hour to increase your productivity. Be aware of where you are geographically. Carry the tools you need. Erica Lee here, probably really happy about her fanny pack. Forecast into the future. So think, a couple steps ahead of where you need to be. Definitely dictate. Autopilot whatever you can. Run the board with your learners and make sure you eat something. So that's a bit of a whirlwind on those 3 topics. I'm happy to hear any questions or if anyone has extra pearls that they want to drop. And then, like I said, everything that I've talked about is on the EM Ottawa blog already.